Okay, so welcome back to the workshop on ECG, and we are going to look at today about the continuation of the discussion on various arrhythmias. As you have already seen earlier, we have looked at the clinical correlation of some of the arrhythmias. Particularly, we understood 3 or 4 important things. One thing is where exactly is the ectopic impulse starting? Is it in the sinus node? Is it in the AV node? Is it in the AV junction, or is it in the ventricles? Is it in the sinus node, atria, AV junction, and ventricles? Second thing is what is the rate? Is it normal rate or increased rate or decreased rate? Third thing is it antegrade conduction or retrograde conduction? And fourth one is regularity. Is it regular or irregular, irregularly irregular, regularly irregular, or very erratic? So these are the 4 parameters which we have looked at, and then we have also looked at the impulse propagation in case of premature atrial contractions. And then we have seen the 3 fates, fate A, B, and C. A is it will not get conducted because it does not cross the AV node and the bundles. And B is the one which crossed the AV node, but it could not cross the right bundle. So there will be a right bundle type of picture, that is RBB type of picture in the conducted beat. And C is, of course, it has cleared both AV node, LB, and RB. So class like so AV, the C is one which has already is beyond the bundle as well as the AV nodes and both the bundles. So it gets conducted as a normal beat. And we also knew that if the rate is decreased, that A will not be conducted, B becomes CA, and C becomes B, and D will be the one which is conducted. And if the heart rate is faster, the reverse happens. So this also we understood. We also looked at the atrial tachycardias, atrial ectopic beats rather, and also looked at the atrial flutter and atrial fibrillation. So today we are going to start with the atrial tachycardia. So ectopic atrial tachycardia. So let me see if everybody is there. Okay, fine. So that means normally the tachycardia occurs from the sinus node. It is called sinus tachycardia. That means the beat is originating from the sinus node, and complexes are P, Q, or ST is perfectly the same as any normal in ECG, but there is an increase in the rate. Okay. Supposing the impulse is not generated at the sinus node, but in an ectopic focus in the atrium. Then what happens? The atrial rate can be very high. So it can be around up to 250, it can be there. And this rate, all of them may not be conducted. There may be 1-to-1 ventricular response, or there may be 1:2 response, depending on the refractoriness of the lower conducting pathways. Okay. So, as soon as they join, they don't have the thing to mute it. Okay. Ectopic atrial tachycardia is, these are of course ectopic beats. How do I know ectopic or not? Depending on the shape of the P wave. Because the one which is originating in the sinus node will have a particular shape. And if it is originating in a focus distal to the sinus node or away from the sinus node, it will have a different shape. And discrete looking, that is very separately looking, unifocal P waves with an atrial rate of 250, less than 250. If it is more than 250, it is fibrillation only, because there is no contraction going on there. Ectopic P waves usually precede the QRS because it is from the atria only they are coming. The QRS is due to ventricular activation. So the beat comes from the atria and then hits on the AV node and then produces the QRS later on. So the P wave is always preceding the QRS in a case of ectopic atrial tachycardia. And the P-R interval, that is the ectopic beat to the R, is called the P-R interval. Normally, PR interval, we know the beginning of the P wave to the beginning of the R wave. Here it is beginning of the ectopic P wave to the R wave is always less than the RP interval. What is RP interval? That is the, the regular beat RP dash interval. So RP dash, and I'll explain you with the ECG. Ventricular response may be 1:1 or with varying degrees of heart block. So if it is 1:1, 250 will be the ventricular rate. Then it becomes a supraventricular type of tachycardia, or it could be blocked by 1:2, 1:2 or 1:3 or whatever it is. Especially in digitalis toxicity, as shown in the 3-lead ECG with a 2:1 block that we are going to see. So, what are the conditions that should be performed? The P wave should be discrete looking, number 1. Number 2, the unifocal P dash waves, the atrial rate will be less than 250, but never more than 250. It could be anywhere beyond the sinus rhythm. Then, the ectopic P wave usually precedes the QRS complex. Okay, that also because it is originating above and coming down. And the P dash or P dash R interval is less than the R dash P interval. That is the R wave to the next P dash, next complex, next ectopic complex. From the R dash to the next P will be some interval will be there, no RP interval. So not the regular P, this is the ectopic P. So it is less than that, obvious, that is there. And ventricular response maybe 1:1, maybe 1:2, depending on maybe 2:1 or something like that. So 1:1 or 2:1 or 3:1. So let us see the ECG of this. This is ectopic atrial tachycardia. One thing, it is faster. Second thing is it is originating in the atria. Third thing is it is not from the sinus, not from an ectopic focus. That's why it is called single ectopic focus is called ectopic atrial tachycardia. If it is multiple atrial foci, then it becomes multiple atrial tachycardia. So let us see first a single focus one. So this is due to digitalis toxicity. Now, first of all, let us look at the P waves. I'm going to put a little enlarge this. Okay, you should be able to see now very clearly. So this is the normal looking P wave, and then you see there is a distorted P wave here. There is already another distortion here. So this is another P wave. This P wave is not conducted, whereas this P wave is conducted. This P wave is not conducted. This P wave is conducted. So you now see the interval between the P waves. So this is the interval here, and this and the next P wave. This is T wave on which the P wave is coming. Look for P in T. So this is shorter and this is longer. Okay. Now, if the beat is conducted, it looks like this. If the beat is not conducted, there is a mystery. There is a block. So that's why every P wave is not followed by a QRS here. So now, what we have to understand is the P wave should be discrete, separately seen apart from the QRS complex. That's what we are able to see here. There are P's here, separate P's without the QRS, discrete PRS count. And then rate. What is the rate like? Let us look at the rate here. This is 300 and this is 150. So it's not more than 250, but more than 100. So the rate also is commensurate with that. Then, since it is originating in the atria, the P wave will be followed by when it is conducted, will be a regular QRS complex, and P wave precedes the QRS complex. So these three conditions are satisfied. Then next thing is P dash R interval. What is P dash R interval? P dash R interval, if this is the P dash ectopic P, and then this is the R, this interval is longer than RP interval. So let's say this is the R and the next ectopic P. So this is the relation they are mentioning. Now, so let us see here. You have to observe these things in lead 2 and V1, and of course these are the two important leads. P wave axis is normal. That's what is there, because P wave axis is normal because it is originated from the atria and coming down. And we can see a 2:1 block for every 2 abnormal P waves, 1 normal QRS is in 2:1 block. Non-conducted P wave hides in the T wave. That also we have seen. The non-conducted P waves are hiding in the T waves. Conducted P wave often has a longer PR interval. So if this is a conducted P wave, so this is the conducted P wave. Conducted P wave, what is the PR interval? It is definitely more than 0.2 seconds. Conducted P wave has a much larger interval. This is the much longer interval. That also is satisfied. And then you see the PP interval may not be exactly regular. That also we have found the PP interval here. So this is the PP interval, and this is the next PP interval. Then this is not exactly regular. So all the four conditions, the P-axis is normal because the impulse has originated in the atria. It tells that the impulse is coming, ectopic impulse is coming from the atria. Second one is non-conducted P waves are hiding in the T waves. That also we have seen. And conducted P wave often has a longer PR interval. That also is seen. This is the conducted P wave and the QR is there. And the PR interval is more than 0.2. And the PP interval may not be exactly regular because see this PP interval and this PP interval. So there is a definite relationship is not there because one is bigger and one is smaller. This is what exactly P dash R is less than the R dash P is less than the P dash R. That's what the previous statement we said. P dash R interval is less than the R dash P interval. That means saying that the PP intervals are not exactly regular. When does this occur? This occurs usually in digital stochasticity. So in order to diagnose EAT or ectopic atrial tachycardia, the following conditions need to be fulfilled. We must have an ectopic origin of the P wave as seen by discrete looking P wave. This must be always of the same type. And when it is conducted, it will be seen before the QRS. When it is non-conducted, it hides in the T wave. P on the T, and the rate should be less than 250. Ectopic P wave usually precedes the QRS complex when it is conducted, and the PR interval, P dash R interval is less than the R dash P interval, or in other words, the P dash R intervals are not constant. Ventricular response may be 2:1 or 1:1 depending on the conduction there. What we have seen in the ECG is a 2:1 block. So here P wave axis is of course positive. In these leads, P wave axis is normal. Non-conducted P wave hides in the T wave. That we have seen. This is hiding here, and this also it is hiding here, and here also it is hiding. Conducted P wave often has a large PR interval. Of course, that is also there, and PP interval is not constant. So this will tell me that the rate is the P wave rate. We are talking about not the QRS rate. You look at the QRS rate here. 300, 150, 100, around 80. The heart rate is around 80. QRS rate is around 80. Maybe little varying because of this one. But whenever it is conducted, we are seeing almost, the regular QRS complexes there, and it is around 80. But look at the P wave rate. P wave rate is, the lowest was this one and that one. That is 300 and 150, maybe around 140, 150. Between the two, it is around 120. This is even faster. This is 150. So 150 to 120 is the P wave rate. So P wave rate is definitely higher than the heart rate. That also is seen here. Now let us look at multifocal atrial tachycardia. This is called MAT. The same thing as the earlier one, but the problem here is multiple foci from the atria, mostly due to ischemia or due to COPD and pulmonary hypertension. The atria are hyperexcitable, particularly the right atrium, and that results in multifocal atrial tachycardia. Now, what do we see? Definitely the P wave morphology must be multifocal. How do I know it is multifocal? At least, the three P waves should be different, morphologically different. There must be three different morphologically looking P waves. Then only we can say it is multifocal. Okay, multifocal P waves means three different P wave morphologies in a given lead, not in different leads. In the same lead, the P wave should be looking differently, at least three of them, three different types. And then the rate is between 200 to 250, that is the rhythmicity of the atria. And with varying PR intervals. That is important because multifocal means a P wave fired from one focus will produce one type of PR interval. A P wave from a different focus produces a different PR segment. So the PR intervals will be varying. So varying PR intervals, rate between 100 to 250, discrete multifocal P waves at least with three morphologies, should be there, and the ventricular response is highly irregular because we never know when the atria are firing. If the AV node is refractory, the beat is not conducted. If it is receiving, it is conducted. So what will happen? Just like in atrial fibrillation. What is atrial fibrillation? An extended multifocal atrial tachycardia. A multifocal atrial tachycardia is the atria, instead of producing a powerful electrical impulse, if the atria produce fibrillatory impulses, it becomes atrial fibrillation. That's the only difference. So there the P waves are not at all seen. Only instead of that, F waves are seen. Here what are seen? The P dash waves are seen, and these have at least 3 different morphologies. Okay, the ventricular response is highly irregular, just like the atrial fibrillation. Intermittent or alternating with periods of normal sinus rhythm. This could be a tachycardia may be there for some time, then normal rhythm, then again normal rhythm followed by sinus, the normal way followed by sinus, like that, alternating or intermittent. Whereas in atrial fibrillation, we don't generally see such sort of normal rhythm, because atria inherently they lost their ability to fire from the sinus node, and then the sinus normal rhythm will not be seen in that. That is another difference. Seen most often in elderly patients with acute or chronic medical problems like COPD, where the right atrium is very excitable. The right atrial hypertrophy, right atrial electrical activity is highly excitable. The atrial rate, if it is less than 100, then we don't call it as tachycardia. We say multifocal atrial rhythm, because anything less than 100 is not tachycardia. So we then call it as multifocal atrial rhythm. Of course, it is originating from the atria, but the rate has not gone beyond 100. Okay. Now again, I am repeating slowly for your understanding what is multifocal atrial tachycardia. Imagine the atrium, the normal firing area is the sinus node. Here, the firing occurs not from the sinus node, but from the various points in the atrium. Okay, so each point generates a different type of P wave because of its position and in relation to the conduction to the AV node. So the one above will generate a taller P wave, the one very nearer to the AV node focus will generate a shorter P wave, like that. So the P wave will have discrete different morphologies. At least there must be 3 different types of P wave morphology, or even more. This, if it is extended, and if whole atrium is electrically unstable and then not rhythmically contracting but fibrillating, it becomes atrial fibrillation. Okay, then what about the ventricular response? Ventricular response is highly irregular because the impulse production from the atria itself, unlike in the EAT where it is regularly occurring from the atria at a particular rate, here it is varying because it is being triggered from various points in the atria. With the result, some of them are conducted, some of them are not conducted. There is no fixed 2:1 or 3:1 conduction. And because the conduction to the ventricles is rather not regular, you will have an irregular ventricular response. What is the other condition which can produce the regularly irregular ventricular response? Of course, atrial fibrillation. We know that this is nothing but a little shorter version of the atrial fibrillation, isn't it? But the difference between that and this is there are no P waves seen, only F waves. Here P waves are seen, multimorphic P waves are seen. Polymorphic or multimorphic P waves instead of F waves. What is the other difference? This is also irregularly irregular, that is also irregularly irregular. Second important thing is atrial fibrillation. Usually if it is there for days. There is no alternating sinus rhythm there. Here there will be intermittent or alternating periods of sinus rhythm. Okay, and if the atrial rate is less than 100, then all of them will be conducted because the rate is within the normal range, and that becomes a multifocal atrial rhythm instead of tachycardia. Okay, so much of English. Let us see the ECG. Okay, some more explanation. Multifocal atrial tachycardia, selected leads with multifocal tachycardia. It is imperative that we look for this one in the leads where P waves are normally studied. Which are the leads which we normally study the P waves? Lead 2 and V1. So you have to look there only. Other leads, they may appear fibrillary or they may not have proper shapes. If you want to look at multiple shapes, you must go to the camera which is focusing on the atria. And the camera that focuses the atrial activity is on the V1 directly on the right side of the sternum. And of course, the lead 2, which is the representative of the atrial activity. So lead 2 and V1 are the two important things which we have to look for. So what if I look at other leads? You will not be able to see. You will not be able to see the multimorphic nature. For example, when we want left atrial hypertrophy or right atrial hypertrophy, we are not looking at other leads because other leads do not capture the atrial electrical impulses properly. So you have to look at L2 and V1. Remember that. And other leads, the rhythm looks like atrial fibrillation, may not have a proper P wave there. So that is the important thing. And then if no F waves, unlike in atrial fibrillation, irregular heart rate, and instead of F waves, we are seeing what are called the multimorphic P waves. Let us see that. Okay, I'll try to analyze this. So here you can see multimorphic P waves. This is one type of P wave. This is another type of P wave. This is another type of P wave. This is another type of P wave. You see? One shape is here, another 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 shape is here, multimorphic. So the multimorphic waves, at least 3 types, we have more than 3 types. Then what is the atrial rate? Look at the atrial rate. Approximately, let us count from here to here. 1, 2, 3, 4, 5, 6, 7, 8. Let's say up to here. How many here? 8 we have got. Or 9 and 10, let us say. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 13, 14, 15. So 15 into 0.2 is equal to 3 seconds. Okay? 15 into 0.2. Yeah, it is 3 seconds. So 1 minute is 20 times that. 20 into 10 we got P waves. 10 into 20 is equal to 200 is the atrial rate. How did I calculate? I took 10 atrial beats. 1, 2, 3, 4, 5, 6, 7, 8, 9 and 10. And saw how much time those 10 beats took. How much time they took? 1, 2, 3, 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15. Let's say 15 squares. 15 squares are 3 seconds. So in 3 seconds, I had 10 beats. In 30 seconds, I will have 100 beats. In 60 seconds, I will have 200 atrial contractions. So that is the atrial rate. What is the ventricular rate? That again you can see. 1, 2, 3, 4, 5, 6, 7, 8. Instead of 10, it is 8. So, but that also is highly irregular. So, 8 means 8 into, 10 means it is 200. 8 means it is around 150 or whatever is the ventricular response. There is no particular 1:2 or 2:1, sorry, 2:1 or 3:1 pattern. Instead, you see the RR interval is this much here. The RR interval is shorter, again longer, again much longer. So varying RR intervals. If there are varying RR intervals, we cannot use 300, 150, 100 like that. We cannot say. We have to take at least longer strip and work out the rate. That's what we did. Now 3 conditions have to be satisfied. Number 1, multimorphic P waves. We have that. Second thing is irregular QRS. That also we have got. Okay, irregular QRS. And the third important thing is the atrial rate should be between 100 and 250. That's what it is there. If it is less than that, it is called atrial rhythm. So this occurs, when does it occur? Whenever there is a atrial stretch, particularly right atrial stretch and right atrial excitability is more. And there are no F waves here. That is why even though it is irregular, we can't call it as atrial fibrillation. We are able to see typical P waves. In case of atrial fibrillation, we don't see that. So which lead I have to examine? I have to examine lead 2 and V1. Let us see if V1 is there. So let us see whether they have. V1 also they have given. So let us see. Let us enlarge V1. Okay. Here also you can see a multimorphic. This is one P wave, this is another P wave there, this is another type, this is another type, this is again looking a little like that. And again, this and this are looking similar, probably from the same focus, whereas this and this one, no, the similar one. This is again different. Each focus is very, very different. This again looks a little similar to that. So multifocal atrial tachycardia. What is the significance? Why do I learn this? First of all, this can get into atrial fibrillation. Second thing is, this requires immediate management because the underlying condition has to be treated. Otherwise, it can lead into dangerous arrhythmia. So that is the most important connotation. We'll also look at the antiarrhythmic treatments also as a part of this workshop. I asked Dr. Sudhir, maybe after finishing the ECGs, 1 or 2 classes, I will take on antiarrhythmic drugs, because that is one area which you people are not properly informed or trained. So I try to explain that. Okay. So what did we do today? We have understood what is called EAT and MAT very thoroughly. The difference between them being EAT unifocal, MAT multifocal. Their P waves are of the same type, here P waves are of the different type. There the conduction is the 2:1 or 3:1, here the conduction is irregular. Okay, that is the main difference. Okay, if it is multifocal, the chances of it ending up in dangerous arrhythmia is much higher. The irritability, electrical instability of the atrium is much higher. Then we have what are called the supraventricular tachycardia. That is, this is nothing much to do with the atria. Something is happening around the AV node. So the paroxysmal supraventricular tachycardia means, in general, it could be atrial, it could be nodal, also supraventricular, but then it is not ventricular. Ventricular tachycardias are different. So what is supraventricular tachycardia? You would have seen several patients of supraventricular tachycardia, and the definition of that is, these arrhythmias are sulcus moment or reciprocating tachycardias because they utilize the mechanism of re-entry. What is that mechanism? I'll explain you. The onset is rather sudden, usually initiated by a start. It is triggered by a premature beat followed by a run of SVT, and that is why it is called paroxysmal, comes and goes, not fixed. They are usually non-QRS tachycardias. This is another important feature. Unless there is a sort of bundle branch block or ventricular apparent conduction, generally PSVT is a narrow QRS tachycardia. If you have a paroxysmal tachycardia, the first question is it narrow QRS? Yes, it is narrow QRS, then it is supraventricular. Then if it is it paroxysmal, comes and goes, runs of them come and again becomes normal rhythm, yes, it is paroxysmal. Then what is the underlying mechanism? Re-entry. What could be the differences in the re-entry? That's what we will see now. AVNRT, AVRT, SART. Mainly you have to learn these three things. Atrioventricular nodal reentrant tachycardia, atrioventricular reciprocating tachycardia, sinoatrial reentrant tachycardia. So first two are related to the AV node. The third one is of course the sinus impulse is the re-entering through the atria and another pathway. We will see. AVNRT we will see first. So AV nodal reentrant tachycardia, this is the most common form of paroxysmal supraventricular tachycardia. This is what we normally see also. Mechanism, there is a dual AV nodal pathway, an alpha pathway and a beta pathway. All of us, we have only one pathway. In these people, there is an additional pathway called the beta pathway at the AV node. Alpha pathway of the AV node is faster and with longer refractory period. Beta of the AV node is slower in conduction but with a shorter refractory period. Alpha pathway is faster and longer RP. This is slower and shorter. RP is a refractory period. Sinus rhythm uses alpha pathway as it conducts faster. Because sinus impulse is faster, it goes down the alpha, and an early PSC finds alpha still refractory, must use the slower beta pathway to reach the ventricles. Okay. By the time it traverses the beta, however, the alpha has recovered, allowing a retrograde conduction. Very difficult from the English. If we read the English, nothing much can be made out in the mind. Now let us see the diagram. Okay. Now this is sinus impulse. So this is the sinus node and this is the AV node. Okay. From the sinus node, if there is a sinus beat, it comes directly to the AV node and then goes down and produces a normal QRS count. Now, there is a premature atrial contraction triggered just above the AV node, and this has to retrogradely go upward towards the sinus node and also go to the ventricle. This is the premature atrial contraction. That this one premature beat. This premature atrial contraction or premature beat has got, now in these people they have two paths. One is the alpha path, which is faster and longer refractory period, and the beta path, which is slower and shorter refractory period. So what happens once the PSC comes, this part is already made refractory by the previous sinus beat. So we know it is having a longer refractory period. So the impulse of the sinus beat has gone down and produced this one, and it is still in the refractory phase. At that time, this goes and strikes that. So not able to enter. Then if the impulse goes and chooses this part, okay, and then by the time it comes here, it has got two paths, two lines of the electricity can go. One can go down and produce a QRS. The other can go into this in the retrograde fashion. By then this is recovered and this enters, and again this goes on continuing like that. That is why it is called circus. Circus re-entry of the impulse. Again I am telling you, normally the sinus impulse has come and it has impinged on the AV node and then went into the ventricles, produced a QRS. Okay, that's one thing. Next sinus impulse has come. There is a refractory period there. So it's not yet gone into the ventricles. Because of the longer refractory period, it is waiting there, this sinus impulse. But in the meantime, what happened? A PSC has started just above the AV node. This is another trigger from the above the AV node. There is a trigger from the atria. And this trigger also comes with the same electric current. It merges there. But then it cannot go through because both of them are blocked by the long refractory period. Then this current has got a chance to enter into the shorter refractory period, slow conducting beta pathway, enters here and reaches the end of the AV node. When it reaches the end of the AV node, it has got two possibilities. It can go and trigger the QRS, of course it does, and it can also enter in a retrograde manner. Because it is coming from this direction, it will not go back in this direction. Instead, it will go into this channel, and that channel perpetuates like that. This is the electrically active AV node, and that is the re-entrant. That's why it is called AV nodal re-entrant tachycardia. So what will come? We will have an ectopic beat. This is an ectopic beat. This is an ectopic beat, PSC, and this is a normal sinus beat. Then the ectopic beat, which triggers the supraventricular tachycardia, and it will be tachycardia because one impulse is directly coming and activating, and it is continuing. It doesn't have to come all the way from here anymore. Now it is being perpetuated here. Okay, that is why there is a supraventricular tachycardia. What is the nature of the QRS? Of course, it will be narrow QRS because it is originating above the ventricles. And anything that is in the bundle is conducted into both the branches nicely, and a synchronous ventricular contraction, and this one can occur. The rate may be 200, 250. Patient will be distressed because the ventricular filling is affected. With that tachycardia, hardly ventricle has any time to fill. So naturally it will lead to ventricular dysfunction and hypoxia unless it is immediately terminated. But the good thing about that is it is paroxysmal. At some point what happens is AV node realizes this re-entry fellow is not the true fellow who has to go down this way. It will say, oh, why are you coming from this side? You are not supposed to come this side. Then it will block that and the tachycardia stops. In other words, the AV node, there will be some electrical changes in the AV node which will not allow the re-entry at some point and will terminate. The drugs that you give also do the same thing. They prevent the re-entry here and terminate the SVT, supraventricular tachycardia. I hope you have understood with this diagram. Now you see this is a normal sinus beat conducted, and this is an ectopic atrial impulse is there, and that produces small deflection there, and it is conducted down and produces QRS. It entered again and retrogradely activating the atria, and then it is conducting like that. It is. If this is the RR interval, and see the RR interval here, the RR intervals are much shorter. So this is the normal, probably that side is the RR interval. This is the ectopic beat. And this much is the RR interval. Now we have got so much of narrowed RR intervals, which means there is a tachycardia, supraventricular tachycardia. Now let us read the English now. This is the most common form. 50% of all PVSTs are like this. Okay, 50% are like that. The second thing is the mechanism is dual AV nodal pathways, an alpha pathway and a beta pathway. Alpha pathway is faster and long RP, beta pathway is slower and short RP. Sinus rhythm uses the alpha pathway as it conducts faster. That is the normal thing. An early PAC finds the alpha still refractory and must use the slower beta pathway to reach the ventricles. By the time it traverses the end of the AV node, however, the alpha has recovered. This allows a retrograde conduction back to the atria. That is why the supraventricular tachycardia. Now you see, AV nodal re-entrant tachycardia, AVNRT, also one form of supraventricular tachycardia. So because the conduction is going backward, first of all you have to see a run of tachycardia. It must be narrow QRS. Okay, what is the heart rate here? So let us say, this has fallen on the dark line. This is 300, this is 150, maybe 170, 160 like that. 170 is the heart rate. Now this is the normal beat, which is now V1 always is like this only. And you see the QRS duration is not more than 2 squares. 2 squares is small squares is 0.08. QRS duration is not prolonged. So it is a narrow QRS tachycardia. There is tachycardia. There is a narrow QRS tachycardia. You see the P wave is impinging back and coming here. Sometimes it goes there. Sometimes it is here. You can see the notch because of the retrograde conduction. Regularly it is coming there. So the antegrade flow into the ventricle and the retrograde flow into the atria. And the beginning of the T wave, you can see the P wave there, notching of the P wave. Okay. The retrograde P is also called the atrial echo. Normally it is coming from that. When it is coming reverse direction, we say echo or pratidhvani. It's often simultaneous with the QRS. That's what we are seeing. It's simultaneous with the QRS, therefore it may be merged in the QRS. If it is slightly delayed, then it can be seen after the QRS. It can re-enter the AV junction because of the beta short refractory period. Okay. So first of all, we have to find out the ventricular rate, and it is a regular ventricular rate, no irregularity, super regularity. And there must be a sort of P waves which are seen, either not seen when they are in the QRS, or they are seen after the QRS, as a similar monomorphic P waves will be seen. And this is the abnormal one which triggered all that. This is the PVC, which triggered the ventricle. That morphology will be different from all other morphology. This is the PAC and this is the SVT. Monomorphic T waves, monomorphic P waves, and then tachycardia. And second thing is QRS is not widened, narrow QRS tachycardia. Okay, so this is a AV nodal re-entrant tachycardia. Now, so this is the same. And if you see the ECG, maybe I will enlarge this. You can see that. We have to see in L2 or V1. Can study either of the two. You can see here the heart rate is this is 300. slightly less than 300, much more than 150. So around 220, 230 QRS complexes are narrow QRS, and there is no widening of the QRS. This one, it's a run of PVC. You can see a run of PVC, and the P waves sometimes they are merged in the QRS, sometimes they may be visible after the QRS. Okay, so that is how the AV nodal reentry. Now we come to the AV reciprocating tachycardia, which is called the AVRT. This is what is called your WPW syndrome. Okay, so look here, the sinus node. Let me see. Now this is the sinus node. Normally it comes to the AV node and it should go like that, and through the bundles it activate. But in these people, there is an accessory pathway. From the atria to the ventricles, there is another door through which the impulse can enter into the ventricles and produce a contraction. Usually it is on the right side. Sinus node, right atrium, right ventricle, there is an accessory pathway on the right side. It is usually not this side. That is why what will happen, the early part of the activation of this part of the right ventricle is now towards the lead. This is the exploring lead. Let's say V5. And so it produces a small, not a very strong like QRS, a big QRS, but a positive deflection, and that is this wave. The first thing is the P wave because of the atrial contraction. The second thing is early ventricular activation through the accessory pathway, right ventricular activation producing what is called a delta wave. And then this impulse merges, and in the meantime that also comes and activates the ventricle, left ventricle, produces a QRS, and it fuses. Normally this is the Q and that is the QRS, and then there is a fusion B delta, and this one it looks like a sort of slanting or sagging and first part of the QRS, and that is the delta wave. And normally this will produce when the T wave is upright, R wave is upright, T wave is also upright. Because of the apparent conduction and the reversed recovery, then there will be a negative T wave. Must have. And another thing is, normally the PR interval is from here to here. Here the P wave is, R wave is lifted, the PR segment is lifted. So it starts, PR segment starts here itself. So the PR interval appears to be shorter. Normal PR interval is due to this, but there is an apparent conduction, so there is a PR interval short. Three things should satisfy. One, short PR interval. Two, a delta wave. Three, a widened QRS. Because of all this PR segment is merged in the QRS now. That's why it is a widened QRS and an inverted T wave. This is the WPW. You may get a short notes also to write. In that case, you have to put this diagram and write. This is the left atrium, sinus node, right atrium, AV node, accessory junction. Why this is important? We do electrical mapping and exactly pinpoint where exactly is this pathway, and then radio ablate it. Do a radio ablation. Even in the other case also, we will radio ablate the pathway. Here, we will cut off this pathway by radio ablating so that there is no circus here, only the regular pathway is open. By radio ablation, after doing a electrical mapping and finding out exactly the location of the beta pathway there, exact location of the accessory pathway in this particular case. So this is WP. What are the characteristics of WP? Number one, shortened PR interval. Actually, it is not shortened. The PR interval regular is okay, but there is an extra conduction, so it appears it is short. Second one is the delta wave is starting. What is the delta wave? Excitation of the right ventricle, merging with the excitation of the left ventricle. Then there is a wide QRS and an inverted T. These three features should be there. Okay? And the heart rate is of course a little faster because the accessory pathway, the very quickly the ventricles are activated, and this activation spreads directly to the ventricle and results in tachycardia, but not very higher heart rates. Now you see this. Okay. Where do I study the QRS prominently? For me to study the QRS, best one is L1 or V5, V6. Look at V5, V6. There is an initial delta wave. See, normal, this sort of slanting you can see here. It is not exactly like, even here also you can see the delta part. So that is the delta wave, and PR interval is very short. and then the inverted T waves are seen. And three features we require. One is the short PR interval, two is the delta wave, and three is the widened QRS. You can see here the QRS is 3 small squares. And that means it is around 0.12 seconds or more. Then why is this not a bundle branch block? This is not a bundle branch block because if it is a left bundle branch block, we see an M pattern, which is not there here. This is something like a delta pattern. Okay. And second thing is in bundle branch block, there is no business for us to have a shorter PR interval. Here there is a shorter PR interval. Of course, the QRS will be lengthened in both the cases, but here absence of M pattern or W pattern in any one of the left-sided leads here or in the right-sided leads and shorter PR interval, though the QRS is lengthened, tells me it is not left bundle branch block, but it is WPW syndrome. But there should be heart rate also should go up. What is the heart rate in this case? 300, 150, 100. So around 100 tachycardia is there, but not 200 or like that. Here the tachycardia is not marked. It is rather around 100 or 120 like that. Okay, this is around 100 in this particular ECG. Okay. So again, the features are number one, there is a shortened PR interval. Number two, there is a delta wave. Number three are more squares of QRS, that is the lengthened QRS. Not because there is a bundle branch block, but because the early excitation of the right ventricle merges the PR segment into that, and there is a T inversion in the opposite side of the T. Here it is tall, it will go down and like that. In the left-sided leads, this has to be looked at. L1 AVL and V5 V6, because there only we can study the QRS complex very well. In other leads, we will not be able to study well. So this is where we have to look for. Now, the next one is sinoatrial reentrant tachycardia. Sinoatrial reentrant tachycardia is a rare form of supraventricular tachycardia where the reentrant circuit or reentrance is occurring between the sinus node and the right atrium. There where it occurred between the atria and the ventricle. Here it is between the sinus node and the atria, nothing to do with the ventricle. So the ECG looks like a sinus tachycardia only, but the tachycardia is paroxysmal. The difference between a sinus tachycardia and this one is, this is started by a premature beat and suddenly it stops. It is paroxysmal, starts and ends abruptly. For all practical purposes, looks like a sinus tachycardia only, but it is triggered by an ectopic focus, so it is paroxysmal. You see here, what is the tachycardia here? 300, 150, 100 is the heart rate. And the P waves of the ectopic starting here are all looking alike. There's no difference. Whereas the normal P wave, after the episode has stopped, then you see the normal P waves. So that's why it is paroxysmal in nature. And we don't see the delta wave there. Okay, and we don't see every P wave is conducted. There is nothing that is not conducted. So it is not ectopic atrial tachycardia, or it is not multifocal because everything is looking normal. The RR intervals are constant. There is no irregularity, no delta waves, no PR segment is widening, no QRS widening, narrow QRS tachycardia. But only thing is, this looks like a sinus tachycardia. If I don't show you this part and only show the left part, and it looks like sinus tachycardia only. But immediately I see if it is paroxysmal, then I know it is sort of sinoatrial reentry tachycardia, also called the SART, S-A-R-T. Now, there are 2 or 3 more that are important for us, and we will do them and stop. Junctional rhythms or junctional escape rhythm is a sequence of 3 or more junctional escapes. At least this is, you see, here at the AV junction, the impulse is not conducted and there will be a marked bradycardia. What is the heart rate here? 300, 150, 100, 75, 60, 50 is the heart rate. So there will be bradycardia because the junction is escaping the firing from the atria. Junctional escape. So it's not conducting the beats and it is escaping, and it conducts at exactly a default rate of 40 or 60 junctional rate only will be kept. 12 lead ECG above illustrates a junctional escape rhythm in a well-trained athlete. Retrograde P waves are hidden in the ST segments. You can see here, this is a retrograde P wave. This is also retrograde P there. So you can see the retrograde P waves are falling on the ST segments. Particularly in the L2, you can observe the retrograde P waves are very well seen. In V1 also, you can see the retrograde P wave is impinging on the ST segment there. So the retrograde P waves indicate that from the junction it is going backward. That is why it is a junctional escape rhythm. Then ventricular ectopics. We come to the ventricle. So these are atrial ectopics. We know. These are the atrial ectopic. This is the atrial ectopic. So this is also an atrial ectopic, and these are the ventricular ectopics, where the Bijare pattern is there, and then the QRS duration will be longer. They may occur in runs or they may be isolated. If they occur in runs, it becomes ventricular tachycardia. Ventricular premature beats are the indication of ischemic heart disease, and they may progress on to ventricular tachycardia. Note the premature ectopic beats marked as VPCs. These occurred before the next expected QRS complex. So this is the QRS and the next expected is somewhere here, but this occurred prematurely. This is the expected distance. But here you see before the distance of here, the distance is 1, 2, 3, 4. This is 1, 2, 3, 4. It should have occurred here, but it started here itself after 2 squares itself. So this is occurring much earlier than the expected QRS. Each PVC has no definite P wave preceding. That also we see here. This PVC doesn't, for example, you see a PVC, there is no P wave there. Here, of course, it's merging with the T. We can't say here there is no P there because these are originating in the ventricle and then not conducted above. And then QRS complexes are wide. Of course, there will be more than 0.12 seconds. These are funny looking beads. It's also called FLB or a Bijare shapes, which you can see the Bijare shapes there. These are VPCs. Now, ventricular tachycardia or VTAC, a dangerous arrhythmia. A wide QRS tachycardia is sustained monomorphic tachycardia. AV dissociation strongly suggests ventricular tachycardia. Fusion beats or captures often occur when there is AV dissociation. QRS morphology should be studied in lead V1 to V6. V1 or V6, funny looking beats will be there. Bijare frontal plane axis will be somewhere around plus 150 to minus 90 degrees centigrade, minus 90. That is in the northwest quadrant will be the axis. Northwest, written here, northwest quadrant. QRS morphology similar to the previously seen PVCs, but then there are runs of them. All QRS complexes from V1 to V6 are in the same direction because the focus is the same. They are not in different directions, especially wide QRS complex. See that. Here, it is the morphology of QRS V1 has a distinct notch in the downward stroke. So you see here and there is a notch. Yeah, you can see here also. Yeah, this is that notch I am talking about. Okay, downward stroke, highly unlikely. Why is it not RBB? If it is RBB, we get what is called an M pattern there. And we get a sort of slurred R waves here. Okay, slurred S waves and the M pattern there. And what is the axis here? The axis is right axis. Right bundle branch block will not have a right axis. Right bundle branch block will have a normal axis. So because of the right axis, present here, and also because there is no M pattern, this notching there is because of the ventricular ectopic focus firing it, and a very wide funny looking beats in V1 to V6. This QRS is entirely negative in V6. That means this is originating in the right ventricle. Where is this originating? Where is the focus now? Because it is right ventricular, I am seeing a positive deflection in the right-sided lead and a negative deflection in the left-sided lead. Supposing the picture is reversed and these are there and there here, it means it is originating in the left ventricle. The direction of ventricular activation is from left to the right because direction of ventricular activation is left to the right. That is why it is going towards the right-sided lead, left to the right. That's why there is a positive deflection. Because it is going away from the V6, it is a negative deflection here. So the direction of current here is left to the right, posterior to the anterior. That is why just like a posterior infarction, we are seeing here. They are R/S ratio more, suggesting because these are positive, that means the current is going towards the right ventricle. That means it is originating in the left ventricle. On the contrary, if this is negative and this is positive, then we expect it is originating in the right ventricle and coming towards the left ventricle, then it is the right ventricular. So this is a left ventricular tachycardia. This is a tachycardia because what is the heart rate? Heart rate is okay, take something which falls. So maybe 300 and then 150. Around 150 is the heart rate. This notch is important, and the direction that R waves are positive in V1 means the current is going towards the right from the left and from the back to the front, suggesting that it is the left ventricular origin. So there are 4 steps of VTAC diagnosis. Absence of RS complexes in all leads V1 to V6. Small r, DPS. We don't have that here. RS complexes. Diagnosis is ventricular. Step number 2, that is not there. The interval from the beginning of the R wave to the nadir of the S wave is more than 1. You may see there is a little RS complex here. But next question is, from the beginning of the R wave to the nadir of the S wave, that is beginning of the R wave to the nadir of the S wave, what is the distance? Is it more than 0.1? Yes, it is there. Ventricular tachycardia. If it is not there, are AV dissociation fusions capture seen? Are there morphological criteria for ventricular tachycardia present both in leads V1 and V2? Any one of these things, steps are positive, then it is the case of ventricular tachycardia. So here, we stop here. These are the, hereafter we have one more session, which is about the miscellaneous conditions of the ECG. Now, I have given you the exercise of 50 ECGs. I hope you have, you are looking at them and coming out with the answers for those things. And let me see them by Sunday, 13th, at least 25 of them. And that we will discuss in the next Tuesday. And then if you complete the remaining 25, we will look at them in the next Thursday, or we will complete the miscellaneous part on next Thursday. And then maybe we look at the answers for them on the ensuing Tuesday. So in the meantime, I'll prepare another 25 ECGs with arrhythmias and miscellaneous conditions. That will be the final assignment. You had one already, first one, basic things. And then second thing, you have 50 ECGs of without arrhythmias. Now arrhythmia ECGs around 20 ECGs, along with 5 of the miscellaneous conditions I will give you. And you try and answer the first 25 ECGs. If all of you have submitted the ECGs, we will discuss them on Tuesday. And the remaining 25, somewhere during the next week, you submit. And the week next, you will be answering the 25 more ECGs which I will be sending. So are there any questions?